Because it is a public meeting, the recording will be posted on the advisory committee's web pages shortly after the meetings. And for everyone's reference, today's agenda can be found under the first tab in the materials. I'd like to welcome advisory committees of both advisory committees today. It is now 2:03 p.m. And I call this meeting to order of the Advisory Committee of Data Issues and the Advisory Joint Meeting of the Advisory Committee of Providers and Carriers. To order. My name is Mandy Weeks-Green, and I'm the Board and Commissions Director. And I would like to give a warm welcome to everyone joining us today. I look forward to engaging with each of you as we begin this exciting work. I'll start with a brief overview of the agenda, which is primarily focused on the benchmark. So today we'll learn about the benchmark from Vishal. We'll have public comments before that, and then afterwards we'll follow that with some updates, looking at the year ahead of us, and also we have some new materials that we just included in the packet, and that is the provider reports for the previous benchmark data. I encourage committee members to ask questions and to provide feedback to help facilitate our discussion and recommendations to the board. I want to thank you all for your time and efforts. So I'll turn to roll call, and I'll call on members by their first name in the order listed on the agenda, which is alphabet order by last name. When I call on you, please unmute your microphone and let us know that you're here. And what's your favorite thing about this season? And then please mute your microphone again. I will start with the Advisory Committee on Data Issues. Krista Abel.
Good afternoon. Krista's here, and favorite part of the season. It's very difficult right now to think about that as it's pouring down rain. It's cold and I can't walk my dog as much as I like to. So I just think we're just all lucky to be alive and doing well. So that's all I'll say.
I hear you. We were just talking about walking the dog earlier. Megan Atkinson. Megan Atkinson. Amanda Avalos.
Hi, good afternoon. Amanda Avalos. I'm here, and my favorite thing is the possibility of snow.
Thank you. Jonathan Bennett. Jonathan Bennett. Bruce Brazier. Bruce Brazier. Jason Brown. Jason Brown. Chandra Hicks.
Hi, I'm here.
Thank you. Oh, do you have your favorite part of the season to share?
I think I joined late. I don't know. I'm not a big fan of winter.
That seems to be what the share is today. Leah Ho Marshall.
I'm here. I think playing in the snow, but in the mountains, not here.
Not in the wet snow. Li Chao Lee.
I'm here. So my favorite thing to do during the seasons is being able to travel to warm places.
There. David Mancuso.
Yes, I'm here. I think my favorite part of winter is that it eventually ends.
That's in a strong theme right now. Anna Morales.
Hi, I'm here. I think I'm enjoying the seasonal winter Starbucks drinks right now.
That's excellent. Hunter Plummer.
Hi, I'm here. And I would say, continuing on theme, it's a lesson of gratitude. So the 4:30 sunsets just reminds me how grateful I am for our summer weather.
Thank you. Mark Pregler.
Yes, I'm here. Boy, I may be the oddball, but I love the winter weather.
All right, what's your favorite part?
It's all of it. I love the rain, the cold, the snow, the mix, everything that comes with it.
Excellent. Russ Schust.
Hi, I'm here, and I'm similar to Hunter. I like that we've made it through the hardest part of winter, and now the days are getting longer. But probably my most favorite is hot coffee tastes better on cold mornings. Yeah.
True. Mandy Star?
I'm here. My favorite part, the rain. That drought this past summer was bad, so I'm glad the rain's back.
Right sides. Julia Sylvester?
Yes.
Julie, sorry. Sorry,
No,
Julie.
no worries. I guess the only thing positive I can think of is when I sit on the couch at night watching a Netflix series, I don't feel guilty. Like I feel like I have nothing else to do. It gives me time to get caught up on all the series that people talk about.
That is a good point. I'll turn to the Advisory Committee of Healthcare Providers and Carriers now. Bob Crittenden?
This is Bob, and I actually like the fire. We get the fireplace going. I like a cup of coffee. It's nice to stop at a good coffee shop and visit with friends. So that part is good.
Justin Vander?
Hey, good afternoon. I'm here. Favorite, probably say my wife and I are happy that our college kids are back to college and not at the house anymore for winter break.
Excellent. Paul Fishman? Paul Fishman? Jody Joyce? Jody Joyce? Louise Kaplan? Louise Kaplan? Stacy Kessel? Stacy Kessel? Ross Larson? Ross Larson? Eric Lewis?
Hi, everybody. I'm here, and I love the NFL playoffs and the days getting longer.
Thank you. Todd Lobishin? Todd Lobishin? Vicki Lowe?
Good afternoon. I'm here, and I would say my favorite part of this season is once I take down all my Christmas decorations, my house looks really clean.
That is a good point. Mine are still up. We were just talking about that today. Natalia Martinez Kohler?
I'm here. Such good answers. I probably could second so many of those. Love the after holiday clean house. I would say probably hot drinks and sitting by the fireplace are the best things at this point while we wait for longer days.
Sounds great. Thank you. Jeb Shepard?
Good afternoon. Like several have said, I like the weather this time of year. I miss it when it's 95 degrees in August, so I'll take this.
Thank you. Dorothy Teeter?
Hello. I guess one of my favorite parts about winter is reading really long fiction novels when you have no excuse but to sit in the early dark and read.
That sounds like a good idea. Wes Waters?
Good afternoon. I'm here, and I guess I'm like Mark, Mark and Jeb and Talia that I like this part of the year, and I'm like Bob that I like the fireplace. So fun part of the year for me.
Well, thank you all so much for your answers today and for being here today. I would like to introduce our new member, Eric Lewis, who is joining the Advisory Committee of Healthcare Providers and Carriers. Eric, would you like to do a longer introduction of yourself for the committee?
Sure. I'm currently the CFO at the Wash State Hospital Association. Been in this role for 4 years, but prior to that, I worked at Olympic Medical Center in Port Angeles for 22 years. And my background is being a CPA in finance and hospital operations.
Thank you, Eric. It's nice to have you on the committee.
It's good to be on the committee. Thanks.
We'll turn now to public comments. Like to open it up to any public comments. I have not received any written submissions for this particular meeting at this time. But if anyone has any public comments that they'd like to make, please raise your hand now. And we will admit you. That process is a little slower on Zoom. And so just if everybody would just give it a moment for us to change people over into panelist modes, if there is anybody that would like to provide public comment. Just give it a minute for anyone to raise their hands.
Hi, Randy. I'm not sure if you called my name. This is Katerina.
Hi, Katerina.
Hi.
No, I didn't.
Oh, you didn't? Okay. It cut out for quite a while, so I wasn't sure if you were taking comments yet.
No, we are taking public comments. Go ahead.
Okay. Quick question for I guess clarification. You did you say at the outset that you would be reviewing the provider report during this meeting?
Presenting on that. Yep.
Okay. My comment pertains to that. Is that provided in the materials in the online, what's currently online?
We'll update those.
Okay. I'll give my comment as it pertains to the provider reports, but we'll have to then review. We might need sort of an update because we have more questions than answers at this point, but we might have answers. So I'll give my comment.
You can always email them afterwards.
Okay, great. So these might change, but this is what we had originally wanted to address, which were the response to questions from the advisory committee members that were from the motion that was raised by WISHA and WISMA's reps on the advisory committees, which the data committee had passed related to the data set that will be available to the providers. Again, I'd like to say that we and our members really thank you for putting it together. The information is really helpful, but I think it still leaves some of the questions and key issues unanswered, and the intent of the questions might not be fully understood. The motion that was put forward was in hopes to have the board provide more useful information to providers that have failed to reach the benchmark, and for the goal in setting this process and to make it most effective, we definitely feel like providers need to believe the data, and that can really only be achieved if there's sort of a mechanism for them to verify the accuracy of that underlying data. And so we were questioning if the providers would be able to do so, and we didn't see a response to that in the appendix. And secondly, we were hoping, that providers will be able to use that data to best understand, where they can make changes to their practices and help reduce spending. We know the board's resources are limited, and so what we're asking for, and I guess what we'll see later in the meeting, is that the template and the data set provide sort of as many useful and helpful analytics as possible so that providers know how to make those changes in the best, most effectively possible. And we didn't see that in the appendix either. So a higher level, asking the board to use, this expertise of these committees, at an early stage to improve the benchmarking process and the progress towards the shared goal of greater access to healthcare services. And these committees can actively assist in developing the most informative template based on the data set collected. So the response was correct in the reports that the original motion had failed to pass, but the amended motion did. And we are fully supportive of the process and having the committees have a chance to discuss these issues and make recommendations to the board. So we hope that staff can put this issue on the committee's agenda in the next several months. Thank you.
Thank you. I do think you'll learn more about this today. And that is the reason why we're bringing it to the committees, is to gain their insights and feedback. If they have any suggested changes to the templates today, it's one of the reasons why it was late, because we've been working on it very, very hard in order to make it to get to the committee today. So I apologize for the lateness, but we've been working sort of around the clock to make sure that we have this template available for you.
No, that's really appreciated. Thank you.
Thank you. Just want to give an opportunity for anybody else who would like to provide public comments. Okay, we'll go ahead and close public comments. And I'd like to introduce our first speaker, Vishal Chaudhry from the Healthcare Authority, who will present on the benchmark.
Thank you. Mandy, do you want me to share my screen?
I think it's up to you, Vishal. We're happy to run the slide deck, but I know you expressed a preference at the board meeting, so we are leaving it open for you as well. Whichever you'd like to do, we'll do.
Thank you. Yes, let me try and share my screen. Please let me know when you guys can see it.
We can see it. We can see it.
Wonderful. Thank you. My name is Vishal Chaudhry. I am the Chief Data Officer for the Healthcare Authority. I'm here to present the preliminary results of our analysis of performance against the benchmark. So just in terms of the outline, we are going to just talk through, what the spending growth looks like, some preliminary results, again, at the state level. I'm noting here that there is some other spending that's part of the slide deck. It's really from other agencies like LNI, and those are the Department of Corrections and VA, and that's part of the appendix slide. The reason they're separate is because they don't neatly fit into one of the buckets of commercial Medicaid or Medicare. And then just a note on the net cost of private health insurance, and we'll see that that is a differentiator between the total healthcare expenditure and the total medical expense that we will see. And as I am going through the slide deck, please feel free to interrupt and ask questions. Happy to engage in a good conversation with the committee. Okay. Just as a refresher, the cost board established a benchmark for 22 and the subsequent 5 years. It represents a common goal for the entire healthcare industry in the state of Washington, and it serves as a starting point. So that's how we've taken this analysis. The performance against benchmark is assessed by measuring the annual spending growth against the annual benchmark target. So just to set the stage and level what we're talking about here. As a reminder, these are the targets starting at 3.2% and over 5 years going to 2.8%. Reminding that it's based on a hybrid of the mean wages and PGSP. What does that mean? It means that the board set the target and there is a good methodology behind it. It means that if and when the board chooses to revisit the target, we have the ability to quantitatively assess the impact of those changes and then recalculate the targets based on new direction from the board. The data are sourced from aggregate expenditure data from the payers, and they include claims-based and non-claims-based expenditures. In terms of the timeframes and the reporting cycles, we are in the first reporting cycle. And as you can see, the intent is to have this analytic report available in late fall every year. What I would note is that this first year, the reporting is only at the state and market level. It does not include provider level reporting. This is just the benchmark analysis and the information. Next year onwards, or actually late this year, we're already in 24, we will start working on the large provider entities and carriers aspect of the performance reporting as well. I also want to note that the workload estimate for this analysis was about 3 to 4 months. That's the amount of time we had allocated for this analysis. And as you guys are aware, due to the delays attributed to data submissions and receipt and validation, the team had about 3.5 weeks to produce this preliminary analysis. I'll be the first to admit that we have a lot of work ahead of us. you know, a lot more questions, and we're gathering those questions so we can figure out what next steps are, you know, prudent to take. But acknowledging that for 3.5 weeks worth of work, this is actually a pretty good data product. It is not very comprehensive. It is preliminary, but it is a reflection of the, you know, the blood, sweat, and tears, if I could say that, over the 3.5 weeks that the analytic team put into it. Definitions. The total medical expense and the total healthcare expenditure are the terms that you will see used in the slide deck. The main difference between the two is the net cost of private health insurance. And that just measures the costs associated with administration of health insurance, you know, including for Medicare Advantage and the Medicaid managed care plans, defined as the difference between the healthcare premiums earned and the benefits incurred. So, you know, when carriers costs for paying bills, advertising, sales commissions, other admin costs, stuff like that. The total cost, the total healthcare expenditure is only reported at the state level. The total medical expenditures are also reported at the market level. And then the process for measurement and reporting, again, the state level is aggregate spending per member per year, and the total expenditures per market. We look at aggregate and PMPY, but for total medical expenditures. And then in the future, like I mentioned, would be looking at the payer and the large provider performance against the benchmark. Oops, sorry. This is just a listing of the data submitters that the team interacted with to ingest the aggregate data and then put it all together and create this analytic report. Just an acknowledgement of the amount of work that these entities went through to provide the data for this report. The next couple slides are about definitions. I'm not going to go through them. They're in your packets for reference as we go through different terms. Again, my intent is not to dwell on the definitions. I will maybe take a couple minutes on these caveats and limitations. I'm not going to read through all of these, but I will note that there are two types of limitations here. One is by design. So for example, the first bullet point, you know, the policies offering limited benefits, they are by design not included as part of the calculation. But there are some that are not by design, but we have had through experience. Like for example, Anthem was not able to submit their 2017 data. Many reasons for that. We didn't get that. Humana Medicare data. It turns out that we're not the only state that has had trouble in getting the Medicare Advantage data from Humana. But those are some of the limitations that we have in the analysis. We're going to try and address some of these, and we'll see where we can get with that in the future years. The other note here is all figures are net of prescription drug rebates, but both the medical and retail rebates have been attributed to the retail category. Just because teasing out the medical versus retail part of the rebate is too complex, and from a macro analysis perspective, did not provide the level of benefit as, you know, congruent with the effort that it demanded. I'm going to pause here for a second, see if there might be any questions. All right.
I had a question. I put it in the chat box. This is Vicky.
Vicky,
So,
I'm not able to monitor chat. My apologies.
I know, it's okay. I know you can't see it. I just was wondering, when you're looking at the fee-for-service program, is the FMAP payment considered in that, or what the state pays is what the feds pay?
Yes.
Okay, thank you.
It's total expenditure, regardless of source. Yes. Jeff,
Jeff,
I see your hand.
Yeah, thank you, Vishal. And I apologize if you touched on this already. I've had some computer issues. Are value-based payments included in these calculations? And if not, is that something that y'all would be considering going forward, or is it done in other states? Just interested in your thoughts.
They are included, but there are limitations to that. I will touch on that in some of the slides in the future. I mean, that are coming up. Is that okay?
Yeah, that's great. Thank you.
Okay. Yep. Any other questions? All right. The highlights of the analysis. So in 2019, the total healthcare expenditure was 48 billion. Well, that's a top line number. We'll see a trend that shows us 7.15 and 5.81. So about between 7 and 6%, if you will, growth per year. Medicare growth rate seems to be slower than Medicaid or commercial, and Medicaid seems to be growing faster than other markets, but the Medicaid expenditure is actually the lowest. So the amount is low, but the growth rate is faster. So these are just some, high level insights from the analysis. So state level data. Like I mentioned, the top line number for 2019 was 48 billion. You see the growth was from 42 to 48. So a 6 billion increase over 2 years. In terms of per member per year, that's where we see the 7.15 and 5.81% increase. I will note that Massachusetts and Rhode Island during the same time period experienced a growth rate of 3 to 4% per annum. I also want to note that those two states have had a similar cost transparency mechanism in place for multiple years. So the total medical expenditure per member per year, and as you can see here, the non-claims bucket up on the top, that is largely reflective of the capitation, the value-based purchasing, and other incentive payments that are not neatly captured in claims. Also a note here that the physician category here includes, and that's a function of how Medicare fee-for-service categorizes their expenditure. It includes the cost board categories of primary care and specialty providers. What I will note here is we see the hospital inpatient proportion decreasing by a couple points over this time period. And at the same time, we see the non-claims expenditure going up by, it's close to a couple points. The rounding doesn't neatly show it. That could be an indicator of, shifting more towards value-based arrangements, which is by design. So, over the past many years, the country at large and the state has been moving intentionally towards value-based arrangements from fee-for-service arrangements. Oops, sorry. These are two bubble charts. I'm not going to dwell on these bubble charts. This one is for the period 2017 to 2018, and the next one is 2018 to 2019. What I would like, I'm not going to dwell on these right now because towards the latter part of the slide deck, there's a comparison slide that has the state as well as commercial Medicare and Medicaid on the same slide. I think it's more meaningful to kind of spend a couple minutes on that particular visual. But I will note here, much of the growth has been seen in hospital outpatient, non-claims, and claims other. It obviously, varies a little bit by market, but on the main, this is where we'll see the the growth trends being the highest.
Vishal, this is Chris Abel. I'm with Virginia Mason Franciscan Health, and I just wanted to mention that there's definitely a lot of hospital inpatient volumes that are dropping and moving to outpatient. Many services that were provided in the inpatient setting are shifting to hospital outpatient. And so when you look at the overall dollars, inpatient, outpatient, hospital combined, it would be useful to know what that looks like combined, because essentially a lot of this activity, it looks like there's a lot of like potential pricing increasing that it's occurring, when really it's shifting from inpatient to outpatient services. And then also helpful to understand the utilization versus the differences between utilization increases and allowed increases. Because based on the cost driver analysis, this was analysis that we looked at last year. I think it was on point pricing analysis, and I don't know if that's what's driving this. There was a significant difference between changes versus utilization versus changes versus allowed amounts. And I think it's helpful to understand the differences between the different products and how those shifts occur.
Yes, thank you, Krista. And that is the intent. I think that's where, the aggregate analysis provides us with what is, and then the driver analysis, which is sourced from the all-payer claims database and other supplementary sources, helps us understand what could be driving what we're seeing. So yes, you're right. By design, over the past almost decade and a half, countrywide, there's been an effort to move care from the inpatient setting to the outpatient setting where it makes sense, and it shows in the data.
Yeah, it was somewhat frustrating because the data that was provided in that analysis focused on, commercial only, and it wasn't called out that over the 4-year period of time, the commercial allowed distinctions, or the difference was I think 2% per year difference per year for commercial, the commercial allowed aspect. And if you looked at the overall picture, including Medicare, Medicaid overall, really the driving factor must have been utilization, since Medicare and Medicaid rates aren't negotiated. They're essentially handed over, and they represent a very large portion of the volumes, at least for the majority of the large provider groups.
Thank you. I think that is good input and feedback for the drivers analysis as we get into them. Thank you. Any other questions or thoughts before I move into the markets?
The only other point I wanted to ask about, and I'm sorry, I'm new to this group, so if let me know if I'm asking inappropriate questions, but I'm just wondering how inflation falls into this. Because inflation rates, recent inflation rates are significant. For example, the Global Insight Index that measures hospital inflation, I think, was 8.6% in 2022. And in fact, the CPI increases or the adjustments made by CMS are in the 4% range. I think they were 4.3%, something like that. I am wondering, as we're in unprecedented inflation times, how these benchmarks are adjusted for that. Are they considered? Because I can't imagine over time, if the inflation situation remains the same as it is, how providers can survive when these benchmarks are set much lower than the actual inflation rates.
Thank you for that. I think the board takes these factors. I think they're supposed to take all the factors into consideration when reviewing the benchmark. I'm gonna move on from the benchmark conversation because I'm here to present the actual performance and what we measured against. You're right; those are the factors that should be considered. And I mentioned in my opening remarks that there is a very defined methodology used to calculate the benchmark. The good thing is that as the variables change, we can revisit that. It's not something that's shrouded in secret. So that's the good thing.
Thank you.
Yep. All right. So moving on to the Medicaid side of things. As I mentioned, the overall spending in Medicaid increased by 11.5% and 9.8%, and the PMPY increased by 13.8% and 11.9%. I will note again that the expenditure levels, the totals, you will see are fairly low, the 4,000 to 4,500 mark, but the percentage increase is very high. I noted this with the board as well when I presented to the board last month, that while you know, we can look at the market dynamics driving certain things, but for Medicaid, the growth rate here is more reflective of the state policy as opposed to maybe just market drivers. Why do I say that? The 2017 to 2019 period was also reflective of a lot of policy changes in the state, up to and including behavioral health integration with managed care. I think Megan Atkinson is part of the committee, and she is a much better spokesperson and expert on this topic. Megan, if you would like to jump in and explain this so I don't muddle my way through it, I would appreciate it. Mandy, I'm not sure if Megan is here today.
Megan is here, but she moved over to her phone. Let me see if I can locate her phone. Hold on just 1 second.
Thank you.
See it. Megan, would you by chance be able to let us know we have 3 phones currently on, 3 phone callers. And so I don't know. Would you be able to message us with the last 4 or raise your hand with the last 4? May not be able to message us because of limitations.
That's okay. Maybe we can come back to it if there are questions
Back
from the
into it in the
committee.
meantime. We'll keep an eye out, see if we can get Megan on.
And if there are specific questions for the committee that I'm not able to answer, maybe we can take it back and get some experts on it. Okay, looking at the spending categories, I want to note over here again the difference between the lowest bar on this, which is the inpatient spend, and the non-claims piece, which has gone, you know, it almost seems like the inpatient spend went down by 2 points and the non-claims expenditure went up by 2 points. In the Medicaid space, value-based purchasing has been a very significant set of activities, especially with the MTP, the Medicaid Transformation Project, as well as the work with integrating behavioral health within managed care. So it is not surprising that those buckets have shifted the way they have. And from an aggregate standpoint, that's what we are able to ascertain as to why the data are changing the way they are. In fact, from 2019 to 2020 and even into 2021, even though 2021 and 2020 data is kind of muddled by the COVID experience, we will see some of these curious shifts as the integration continued on the Medicaid side. Again, with the bubble charts, you will see that the hospital inpatient was a pretty significant increase from 2017 to 2018. But when we get to 2018 to 19, you can see that the non-claims, it's a 38-point increase. And that's where that's where the phasing in of the integration of behavioral health with managed care was really in full steam. So we see that happening in this space, and the data are reflective of that. Any questions before I move on to the next market, which would be Medicare? Okay. In the Medicare space, again, the bars are really high. This is the highest expenditure, and they have been age and sex adjusted, but then again, it is an older population, higher level of chronic disease incidence. So we would expect the total expenditure per member per year to be higher. The growth rate at the same time is one of the lowest amongst the three market segments. About 3% per year, which is what we see in general across the nation as well for Medicare. In terms of per category spending, you will see here that it's the same type of shift from inpatient. However, it's actually going to claims other, which is interesting to see. Not quite sure what the details behind that are. The claims other includes DME and some of the other expenditures. Non-claims would be just the value-based purchasing and capitation arrangements and stuff like that. So these are just some observations that we've seen from the data. In terms of bubble charts, you will note here the hospital inpatient side is a negative 4.56% PMPY. And for 2018 to 19, it remains on the negative side. We've seen the same thing in the Rhode Island data, where their hospital inpatient growth was negative, but the claims other and the non-claims bubbles are leading the way, if you will, in terms of driving the growth rate from Medicaid expenditure. Also, did I say Medicaid? I'm sorry, Medicare expenditure. Pausing here to see if there are any questions specific to Medicare. Okay. Moving on to the last market segment, commercial, about a 5% growth per year. That is total spend. When we look at the per member per year, it's 4.5%, 4% increase, which is very much in line with what other states have seen as well. When we look at it from a spending category perspective, again, we see a decrease on the hospital inpatient side, but that shift actually has gone more towards the hospital outpatient bucket in this, as opposed to like the non-claims or claims other buckets that we saw for Medicaid and Medicare. Also noting that the non-claims bucket is fairly small for the commercial side as compared to the Medicaid and Medicare market segments. When we look at the bubble charts, the one thing I would note here is how small that non-claims, the dark blue bubble is, both for 2017-18 and for 2018-19, you can barely see it. So I'm going to move to summarizing, because these couple slides kind of put the market segment side by side. Just repeating the points that I was making earlier in terms of the per member per year growth, in terms of the total numbers as well as growth rates. It's good to see them side by side. Medicare again has the lowest growth rate, but the highest spend number. Again, acknowledging that that's a different population with very different needs as compared to the Medicaid and the commercial population. And then the growth rate for the Medicaid population or the Medicaid expenditure is the highest at 13.8 and 11.9%. Again, reflective of policy decisions, state policy decisions, much more so than market drivers. And this was the chart that I mentioned earlier where we have the spending category bubble charts by market compared with the state. I will note again here that our premise is that the non-claims expenditure bucket includes capitation arrangements, incentive payments, the value-based arrangements, if you will. And you'll see a large bubble both on the Medicaid and Medicare side that results in a meaningful size bubble at the state level, but that is non-existent on the commercial side. So one of the things that we could be looking at and following up is what is the prevalence of value-based purchasing arrangements and their impact in the state? When we're looking at the commercial market, not Medicaid and Medicare specific. And like Krista was talking about, the hospital outpatient bubble, the growth, we don't see it as much on the Medicare and Medicaid side, but on the commercial side is very prominent, right? So there are, I'm sure, drivers of that. And to understand those drivers, understand the factors that are resulting in this kind of performance, I think would be part of the next steps for us. I'm going to pause here and see if there are additional thoughts, questions, or comments from committee members.
When Vishal, when you talked about the hospital cost is prominent, is that a combined hospital inpatient outpatient increase, or are you talking about the hospital outpatient?
Sorry, I thought I said hospital outpatient, yes.
Hospital outpatient, okay. And again, I just encourage the use of combining them because I think a lot of that is the shifting of services from one setting to another. And the focus on utilization increases, but I'm sure that's part of your process.
Thank you, Krista. Any other comments,
Michelle,
questions?
that Megan Atkinson is available again?
I apologize. What was that? Sorry.
I said, Vishal, I do show that Megan Atkinson is available again if you would like to ask your question.
Oh, great. Yes, Megan, hi. We were going through the Medicaid slides and the growth rates and the time frame from 2017 to 2019. And I remember that you were able to shed light on that in a very meaningful way for the board. So I was wondering if you could, share your thoughts on that.
Yeah, definitely. Hi, everyone. This is Megan. I hope you can hear me. Sorry, I was on my phone and couldn't get unmuted or participate while I was transitioning. But as many of you know, because there's several folks here who are heavily involved on the Medicaid program, is during 2017 to 19 was quite a bit of focus on the behavioral health integration, changes to the way rates were being built for the behavioral health sector, as well as some investments from the legislature on the Medicaid program. I think we will continue to see that even as we look into 2020, 2021, 22. And I think something that the cost board will likely need to consider is how to address programmatic changes. I think the Medicaid program especially is going to be, expenses in the Medicaid program especially are going to be influenced by legislative decisions around covered populations, state-directed payments, and things like that. So I just think we'll continue to need to think about Medicaid in terms of what's actual cost growth versus what is programmatic covered population, covered benefit growth.
Thank you, Megan. Any questions from the committee members for Megan on that topic? All right. The only other point that I wanted to share on this slide, and I think I mentioned it, but on the state bubble chart, you see the three more prominent bubbles, which are reflective of the size of the bubble, which is the total utilization plus the PMPY and the growth rate, are the non-claims claims other, and hospital outpatient. And when you look at the other three charts, you can see that the blue bubble, the non-claims bubble, is primarily being driven by Medicaid. The green bubble, claims other bubble, is primarily being driven by Medicare. And the hospital outpatient bubble, the peach bubble, if you will, is primarily being driven by commercial. So when we start looking at a driver's analysis or drilling down and understanding, okay, this is what we see, what's driving these, and then, you know, as a result, maybe we'll get to what we can do about them. I think there are different focus areas for the different markets that we could narrow into and understand what that is. Krista, you make a good point. That is it just a function of shifting from inpatient to outpatient? Maybe that it is, but still the growth rate is pretty significant, right? So understanding that will help us understand what to do about it and what options might be available.
That makes sense. Thank you.
I saw Eric had come on camera. Eric, did you have questions or thoughts?
Yeah, I just wanted to say, great data. This is something I've never seen before. So I think it's great to have this data. And that in the you know, the benchmark years, we had 6 or 7% growth. And the targets are heading towards 3%. And I was wondering if the committee or the board is going to relook at those targets that they set back in 2021. You know, given, I think the targets were like 70% based on median wage and 30% based on potential gross state product. But was there any plan to update the benchmark, maybe relook at it now that we're maybe two and a half years after it was set?
I cannot speak for the board, but I know that the conversation is alive and well at the board. Yeah, I don't think I have an answer to your question, Eric, except that the board is expected to review the benchmark, and that's why having a set methodology, well-defined, transparent methodology is so important.
Yeah, so I look at the trend we had from 17 to 19 of the 6 to 7%. And I think about the factors that are hitting healthcare costs now, such as labor shortages, inflation, just the cost of treating COVID patients. It's going to be hard to cut that historical percentage in half, given the market forces. But this is really great data, so thank you for sharing it.
Thank you for that comment. I appreciate it. Any other thoughts before we move on to next steps? I realize I have only 4 minutes. Louise.
Shaw,
Yes.
you're welcome to have more time if you need it. We don't have a lot of material after you, so we have plenty of time to flux for any additional questions or time that you need.
Thank you. Louise?
Yes, I just want to touch on what Eric just said about COVID, because when we get into the years where we were at the peak of the COVID pandemic, the costs are going to be very high. And yet the state also got some infusion of money from the federal government. So I'm just wondering how there's going to be some consideration for the costs of the caring for people who were experiencing COVID, dying from COVID. You know, it was a very serious shift in acuity to the extent that even the life expectancy of people in the United States dropped. And then what infusion of money did the state get that may have made it easier to spend the money?
That's a very good point. And I think Megan was alluding to something similar in her comments. And Megan, I see your hand is up. Please go ahead.
I think Louise is raising a good point, right? And I would say actually even it's kind of going to go both directions depending on the segment of the healthcare system that we're talking about, right? Because during those same times when admittedly the hospital sector was hit, very hard, with highly acute patients, then the like primary care providers and others, due to the stay-home orders and things like that, actually had a decrease in utilization. And so it'll be interesting to see how we can help the cost board understand those types of interruptions that impact the different segments of the healthcare system differently, and how to, you're right, tease those apart so they aren't just getting muddled all together in one conversation about what aggregate costs are doing.
That is such a great point, Megan. And Eric, to your point, it is interesting for all of us to see these data, because I don't think any of us have looked at these numbers the same way before, right? So understanding these is the first step, right? What do we do with them? And if we didn't have any benchmark or anything to compare them to, we wouldn't know whether this was good, bad, or ugly, right? So we have something to look at. So from a purely an analytic standpoint, I'm more interested in understanding, well, what's driving these. And as the factors change over the next couple of years, what will that look like? So it's just the measurement of that performance of the system and how that changes over time with those different factors, I think is going to be deeply informative for us, for the committees, and for the board, as to how that results in any changes to either the benchmark methodology or what we do about it or actions. Don't know. But thank you for really good, thoughtful comments and questions. Julie, I see your hand up.
Yes, I just have a couple quick questions. First, where are emergency room claims bucketed under, hospital outpatient or professional other?
They would be a hospital outpatient.
Hospital outpatient. And then my second, and maybe I missed this, do we have an explanation on why commercials claims are missing any green bucket of claims other?
The claims other is primarily DME, and I don't know why they're completely missing. I don't think they're missing. I think it's just really small.
So claims other, we can't be saying that. Oh, okay. So claims other is just, it's solely DME, or is it made up of other?
The definitions are on slides slides 9 and 10. And sorry, my other screen is too small. I can't really read that. But it's DME and a couple other things that is contained in claim other. And that's why you see it on the Medicare side, it is so prominent, because in this country, most of the DME expenditures are actually borne by Medicare.
Okay, great. Thank you.
All right. So moving to next steps. Again, this report is just setting the stage. It presents us with benchmark information. As you've noted, it doesn't even go into provider level detail or carrier level detail, and that was the intent. It is not intended to. It is intended to help us understand how to look at the data, what to make of it, what questions to ask as follow-ups, and how do we then guide the next sets of analysis. It will inform, it is informing our next data submission call. And then we'll get into the deeper dives into healthcare spending. How are the changes in prices and utilization contributing to the point that was made earlier by Krista? There is an interplay there. There's also a report that we're expecting from IHME around similar topics, and then eventually that will help us get to recommending some cost containment strategies or cost growth containment strategies to the board, and we'll go from there. I will stop sharing, and unless there are any questions, I will hand it back to Mandy.
Giving it a second for everybody in case they would like to raise their hands. See anyone? Thank you so much, Vishal. Next, we have under our agenda is sort of informational updates, and included in the informational updates are the provider reports. We have created, and I know that this is very important to you, important to every member of the advisory committee and to the board, particularly providers who are interested in this. So we've sort of created methodology utilized by other states to engage providers in the conversation of their provider reports. So while the 2017 to 2019 data is not necessarily accountability years or benchmark years for people who will be held in against the benchmark, we are creating reports demonstrating that data and giving that to the providers, and including a webinar that will help educate them on their provider reports before we send them. And the plan is to hopefully roll this out to begin the process in about a month or so. As soon as we have contact information, we are working with WISMA and WISHA to identify the providers and ensure that we have all the correct contact information for the providers. So we're hoping that this process, it's not a reporting year, but this process, by utilizing a non-reporting year, can get providers familiar with the process so that when we enter any reporting years, that they'll be educated and be able to ask questions about their data and are fully up to date. And also, these reports will not be public reports. And just as a reminder, the 2017 to 2019 are not public reports for providers or carriers. So these data, these provider reports will only be sent to those entities. On your screen now and in your materials is the cover letter that we've drafted to sort of give people information about the process, let them know, give background on the benchmark, give background on the cost board and the process. And we will also engage them in educational opportunities like the webinar and make ourselves available should they have any additional questions after they receive the reports. Are there any questions or feedback for the cover letters? And again, you're welcome to submit that later after the meeting. I realized that this was sort of relatively short notice. We were really working hard to get this in your materials so that you had this. Just checking. Okay. I will turn it over to Sheriel, who will go over the provider template, which is probably the more interesting documentation. Right now you have a PDF version, but I think Sheriel's going to screen share the active Excel version so that it's a little bit more viewable. When we converted the Excel files, they will receive the Excel files rather than PDFs. So the Excel files are a little bit easier to read. Sheriel is with for those of you who have not met Sheriel, she's with the data team here at the Healthcare Authority Cost Board. And Cheryl Namington, are you able to begin? I don't hear you.
Sorry, yeah. Are you able to see my screen? Okay, sorry.
Oh wait, your screen just went away.
All right, hold on 1 second.
But I see you and I hear you.
All right, are you able to see my screen?
Yes, thank you.
Perfect. All right. Hi, everyone. My name is Cheryl Namingit, and I'm new to the cost board team. I am leading the data analytics on all the data that we will be collecting. So today I will be presenting an overview of the provider report template, which will be populated for each large provider, defined as providers that have at least 10,000 covered lives. So each large provider will receive their own respective provider report, and we anticipate giving this report in the coming weeks. So this is an overview of the template. You'll see that there's a cover page, and this cover page provides an explanation or like a very brief overview of the work of the cost board and of the first data call that was done in 2022. This tab explains that the 2022 data call collected 2017 to 2019 data from carriers, and that the provider data contained in the rest of the sheets of this report comes from this collected carrier data. It also explains that there is no benchmark yet for this year's report and that there will be no public reporting on provider data this year. It advises providers to check if the data is reasonable and that if providers have some comments on questions, instructions on who to contact are also provided on this page. Now, I'm going to go to the other tab, which is a table of contents. This enumerates the 8 tables that will be in this report. So go to table 1. Table 1 contains an overview of the provider's cost growth performance for 2018 and 2019. Specifically, it shows the point estimate and the upper and lower bounds of the 95% confidence interval of the growth rate of the average risk-adjusted total truncated claims expense per member per month by year and by market. And it's important to note that this metric, as mentioned in the manual, is the one that will be used in the future to gauge providers' performance against the benchmark. More details on this can be seen in Table 8, which contains data on the provider's risk score and notes on the risk adjustment and confidence interval calculation methodologies. This table also contains visuals or graphs showing the confidence interval vis-a-vis the overall growth rate for all providers across different markets, as well as the overall growth rate, which is indicated by this horizontal line. In the future, when there is a benchmark, we'll also overlay the benchmark growth rate so that providers can visually compare if their confidence interval is above or below or within that or contains that benchmark cost growth. Now we move to Table 2. Table 2 shows the data, the number of member months by insurance category for the 3 years that we collected data on. And then Table 3 provides like a breakdown of the member months by insurance category and carrier. Table 4 provides claim expenses data. And Table 5, the non-claims expense data per member per month. And then Table 6 provides the total of claims and non-claims, or the total medical expense PMPM by insurance category and carrier. And then moving on to Table 7, we further break down on the total medical expense by service category, by member, by year, and by market, by insurance category. Then Table 8, which contains the data that we provide in the graphs, provides data on the total truncated claims expense, the risk score, the risk-adjusted total truncated claims expense per member per month, and the year-on-year growth point estimate, as well as the 95 confidence interval. And then we'll provide notes on how we risk adjust as well as calculate the confidence interval. And that is the overview of the provider report. We welcome any feedback, comments on the report or template.
Hi, Cheryl. My name is Russ, and I have a question that I can take offline if it's easier, but I'll ask it here first. What's the definition of a provider? Will that be provided with this reporting? And the reason why I'm asking, I work at Optum. As example, we represent providers by TIN as well as carriers. And so this data would get intermingled. So I'm curious how we would report this.
Yes, we have defined in the attachment of the cover letter that will be sent to provider, there is like the definition of large providers in that cover letter. And if you can show that, Mandy, maybe that will be helpful. But we can I refer you to that definition in that Word file because it provides language on large providers and how they were chosen.
We'll get there, Sheriel. Let me just, oh, can you
Stop sharing.
Sure. Yes, exactly.
And this
Joe
is
Shepherd.
Tamara. So there's going to be some feedback.
This is Teresa. Page 2 to 3. Who does the cost benchmark apply to? And then you'll see it begins here at the bottom of the screen. And how we calculated the 10,000 providers. So originally, if everyone remembers, we began with a list of 50 providers identified based off their markets, and then working with the carriers, we narrowed that number down to give their large providers, people who have over 10,000 attributed lives, who also offer primary care services at some level. That number became 33, and working with the carriers, we took the 2017 to 2019 data and validated the 33 carriers, however, the 33 providers, and we ended up with only 26. So it ended up being less after validation than it was before. So that's sort of, that is the methodology that we use.
Okay, that's helpful. Thank you. When I see the list, I might come back with another question, but I'll save it for then. Thank you.
Jeb, this is Teresa Tamara. I'm also helping to facilitate this a little bit. We'll have you talk next.
Hello?
Jeb, we can hear you.
Great. Thank you for sharing this in a draft form. Would it be possible to get a hard copy of this so we can sort of shop it around with our members to get their feedback to help sort of fine tune this if they, to their mind, they identify anything?
Yes, because we are trying to get this out to the providers as soon as possible. Yeah, we'll get you a copy. If you just email me, Jeb, as a reminder, I will email it out to you.
Okay, thank you.
Thank you so much, Jeb. Eric.
Yeah, I'm wondering for the large providers, are they going to get information on which lives are attributed to them from which carriers? And maybe even which physicians are taking care of these patients?
We don't have it down to the physician level that I'm aware of.
Okay, but do you have like, would they know which patients, would a large provider know which patients are being attributed to them?
No, because that would be identifiable information, personally identifiable information. We don't gather that as a part of this process.
Okay, so they're just going to get a number of lives and then a total dollars or something?
Oh, they're going to get the whole entire worksheet that they've got in front of them.
Okay. Okay. Thank you.
Sure.
And this is Chris Abel. How would they audit it? How would they be able to validate the results if they don't know who the members are?
They could work with the carriers to cross-reference the reports, so that the reports might be slightly different than the carriers because of how the sort of differentiation and how this data call works and the carriers. But they could utilize their own metrics and working with the carriers.
Are they based on like attribution models then?
Yes.
Similar methodologies that the value-based programs are using now then?
It's identical to almost every validation model utilized by the other states right now.
Okay, thank you.
Yep. Good question. And I think we even have it in the letter that this is sort of the exact model that Oregon utilizes. Oregon does have a lower threshold. They have a 10,000 lives threshold, and then they also have a 5,000 covered lives attributed based off market share. So if you have over 5,000 covered lives in a singular market, you would also be a large provider. But they have the 10,000 one as well. So they have a two-prong model.
So just this is Krista again. So are the members then attributed based on the employed providers for that large group then? It's basically an attribution model based on your employed providers. Is that correct?
I want to make sure I understand that question. So
attribution is typically based on the primary care providers and or possibly specialty providers based on the attribution model. Then I would assume that this must be driven by the employed providers within each large provider group and the members that are attributed to
I
them.
believe that that answers yes. I'll leave that to the data team to actually confirm that particular component. And I know that that we have worked with others with regards to this too, like Milliman and those types of people that we work with usually. And so we will, Sheriel, if you can't answer that question, we can get the answer to you at another time because the person who specializes in this particular modeling is not here today because they were unavailable for this meeting. So I can't get that question answered to you if we don't have that available through Sheriel.
Yes, we can provide more details on the attribution methodology and email it to you, Krista, so that there'll be more references in that answer.
Thank you.
I'd be interested in that information too.
Oh, that sounds great. I'm sorry, I didn't capture who that was.
Eric.
That was Eric Lewis.
And then we are taking notes of the topics of interest, and we'll make sure that we answer that in more details when we have the webinar with the providers as well.
Great, thank you.
I think we're also working on an FAQ behind the scenes as well for the providers and updating the webpage to contain more information about the data call, specifically targeted towards the providers to get more information.
Yeah, this conversation is really to help us anticipate what those questions are so that we can address them in the data call that we send out with a letter in the FAQ and the webinar.
And we know that this was a component that everybody was very interested in, and so we wanted to get more information on the process and sort of move it to the forefront so that there was an opportunity for large provider organizations to get familiar with this process, so it's not any surprise when it came time to for their reporting year. So this is a really good effort at making sure that they understand the data and information ahead of any of that time and sort of are able to fully engage with us at that time.
Are there any other questions? Krista?
The one thing, other question that just on my mind, as long as you called out my name, is can we, like, for example, could I participate in that webinar? Because I would not be the person assigned because I'm not a data analyst here. Is it appropriate to have a couple people from each of the provider groups join that webinar?
The webinar will be recorded and posted online. We would probably keep the actual live webinar only available to those providers being reported on so that they have enough time and opportunity to ask their questions, but we do intend to record it and we can post it online.
Okay, thanks.
Yeah, we just want to make sure that those providers who are actually going to be encompassed have enough time to engage with us and that it isn't being utilized by providers who are not being reported.
Okay.
But yeah, our intent is to record the webinar and post it online so everyone would be able to view that.
Krista, anybody else? I just said thank you. Any others?
Great, we have one, we'll move on to the last item in our materials. And that is, there we go. I just wanted to share with you the board's work plan. It's a tentative work plan for 2024 and how it is going to be interacting with its advisory committees in the upcoming year. We are super excited about We're very excited. I just made fun of myself. We're very excited for the upcoming year. And excited to be engaging in new work with the board. And that the benchmark is out and will be, we are creating the upcoming data call so that we'll have that by the end of this year as well. The next set of data, and you can see how the board will be interwoven with the committees. And if you can turn to the next page throughout the next year. And then we wanted to include a list of the committees. One thing to note is that we currently have the healthcare providers and carriers and the data issues meetings scheduled at the same time. We think that this is an effort to sort of move towards ensuring that we can communicate data to both committees at the same time, especially needed information like the information that we had today, where it benefits both committees to be involved in the same room at the same time. But if the information and the materials coming from the board are only targeted towards one committee, we'll modify the meeting request and we will ensure that only one member or one advisory committee needs to attend that meeting based off the needs of the board. And as a note, the advisory committee of primary care is going to be moving towards finishing its work in the upcoming year, at least for the year. It will be revisiting the issues around primary care on a regular basis, but more of an annual basis. But it anticipates wrapping up its work sort of in the middle of the year this year. That's the reason why there are no other meeting dates after June 26th at the current time. So it should be having some upcoming reports to the board and recommendations. Any questions? Great. Wow, that was efficient. We are done early. In your materials, you'll also find those materials. I know that many of you were familiar with the appendix materials because you had seen them through the board process, but just in case there was that motion that both committees had talked about a while back, and the committees haven't met since that time. And so we wanted to provide those materials to you as well, in case you had not received that through other channels or were not in attendance at the board meeting on that day. So hope that you find this information really helpful in looking at how we establish the cost driver analysis and how we establish some of these methodologies around it, so that you can, and all of these materials are also posted online, so you can go back and look at the meeting on certain dates if you wanted to, and open the Zoom meeting recordings and sort of see anything that you might have any questions about. All right, everyone. I want to thank you for a great meeting today, and for your attendance. And I hope that you have a wonderful weekend coming up.
Thank you.
Thank you.
Thank you.
Bye-bye.